Dr. Amit Porwal, and he's going to talk on combined cataract surgery with trabeculectomy.
Thank you, Chair and AIS, for inviting me and being part of this national symposium. So I'm going to talk on combined cataract surgery with trabeculectomy, no financial disclosures. So what are the major indications for this? Patient should have a cataract within glaucoma patients where there is failure to achieve target pressures by medications. There are issues related to compliance, adherence, and drug-induced side effects. There's borderline control IOP, disease progression, or advanced glaucomatous optic atrophy despite magical medical therapy. When you have uncontrolled glaucoma, but there is an urgent need to restore vision, or when two operations are not feasible. So basically, these are the indications for the triple procedure. Advantage is being it eliminates the need for two separate surgeries. The early post-operative IOP rise is significantly less. A significant improvement in visual acuity along with the IOP control, and this decrease in the number of glaucoma medications. When we are dealing with these angle closure cases for a combined surgery, there are certain pre-operative considerations which we have to take into account. You have to find out whether the significant visual loss is due to cataract or glaucoma. You have to do a thorough examination because most of the patients will have shallow AC, pseudo-exfoliation, iodorensis, phacodorensis, myotic pupil, or synechitis. Posterior fundus examination should be done to rule out what is the reason for the visual loss, and you can consider intravenous mannitol or acetazolamide if the pre-operative IOP is very high. Operative considerations, you should be well prepared to deal with the myotic pupils. So you should try to use a cohesive or a dispersive, both the visco, and should know when to use. That is very, very important. Rexis site should be of adequate. You should not do a small rexis because if the patient is having pseudo-exfoliation, you might land up in post-operative capsular phimosis. The iodization should be performed very slow and in a controlled fashion to avoid the iris forcing towards the incisions. IOL selections, you can select any of these PMA or acrylic IOLs which are available now, and if at all there is no capsular support, ACIOL has to be avoided. You can implant an SFIL or an iris flow lens, but ACIOL has to be avoided. Intraoperative pulse, start your incision just inside the limbus, create a two-step incision. If you're using a cystotome, try to make a capsular excis. Consider putting the needle on your viscoelastic syringe so that whenever the AC is shallow, you inject and the AC is reformed. As I told you, you should know when to use the dispersive and a cohesive viscoelastic, and you should always suture the corneal incision at the end of the combined surgery. Post-operative management, medications, and the potential complications are the same which you have for any other cataract and trabeculectomy surgery and should be tailored out. So coming to the techniques, there are basically two techniques of combined surgery. You have the single site technique or the twin site technique. Single site technique, that means the phaco and the trabeculectomy is done on the same site. Usually it can be an SICS or a phaco plus IOL plus trab. Twin site, you have the superior trab and a temporal phaco, most commonly done for as a phaco trab procedure. When we look at the studies, single site versus two sites, twin site group had 1 to 2 millimeter more IOP reduction and required less post-operative medications, although this difference was not statistically significant. So I'm just showing a small video of how to do a twin site surgery. The superior rectus suture is taken, and I use a subconjugation of mitomycin 0.02 milligram per 0.1 ml. You should always mark your congenital flap. So in the case of a phaco trab, I'm marking at a 3.5. In one go at the limbus, have one small nick and then separate the tissue and then try to go subconjunctivally as much posteriorly as possible so that you have a diffuse bleb. Once it is done, try to identify the bleeders and only cauterize the bleeder. Don't cauterize generally the whole sclera, because if you do that, if you do excessive cautery because of this, there will be scleral flap shrinkage. Again, mark your scleral flap. So when you mark for 3.5, you'll end up in getting a 4 millimeter. I always do a triangular flap, so it depends on your choice whether you want to do a triangular flap or a horizontal flap. So the depth of the incision for the triangular flap should be adequate. Raise the apex with the help of a Hoskins forceps or a blunt forceps or one-tooth forceps, and try to make the separate the flap in one go. You should have a smooth edge of the scleral flap. Once this is done, then shift temporally and now proceed with your phaco incisions. So the, two side port incisions are done. Staining of the capsule is very, very important because most of the angle closure cases, we will end up in having a mid-dilated pupil, and the cataract also might be very hard. Rexis is marked with the help of a Rexis marker. This gives you a rough guideline that what will be your Rexis size. Follow the whichever routine procedure of your phacoemulsification which are used to. But what I would recommend is to do a slow motion phacoemulsification. You see, the moment I did the hydrodissection, this is a floppy iris, and the whole pupil is become mid-dilated. So whatever technique of your choice, whether you want to do a stop and chop, direct chop, your whatever phaco choice you are comfortable, go ahead with that. Just make sure there's not much of turbulence into the anterior chamber, because if that is there, there will be a lot of pigment release, and these are going to occlude the angles which we don't want. So that's why I recommend slow motion phacoemulsification. Once you are done with your phacoemulsification, inject the IOL, and when you are injecting the IOL, you have to make sure that the haptic, the IOL is inside the bag, and orient the haptic at 3 and 9 o'clock position, because you don't want the AC to be the lens to be the sulcus, because sometimes what happens is the haptic is oriented superiorly through the peripheral iridotomy. What you do, the haptic might prolapse out. So as I told earlier also, always suture the main wound after you finish your phacoemulsification. Now the cohesive viscoelastic substance was there. I washed it, because at this step, I want to go behind the IOL and wash up whatever visco is there. And now I'm going to refill the visco, but this visco is going to be only into the anterior chamber, so that when I'm going with my trabeculectomy, I shouldn't have a VC collapse. You have entered the anterior chamber with the help of a 2.2 keratome and with the help of a Kelly sponge. You just make sure that your internal ostium opening is adequate. I do a mushroom shape internal ostium, and this gives me a better control. So once the trabeculectomy meshwork is cut, then you do a small peripheral iridectomy. Because visco is injected, and always make sure that you don't overfill the anterior chamber with visco. You overfill, you will have a lot of iris prolapse in these angle closure cases. So only adequate visco substance should be there. I'm putting a releasable suture. This is of great help. Always try to put at least 2 releasable suture, one at the apex and one at one of the walls, because these releasable sutures will help you control your bleb, titrate your bleb post-operatively. So the technique of releasable suture is what I follow this. First into the clear cornea, then perpendicular to the limbus, into the scleral flap, and then from the scleral flap into the intersclera. So this is an intermittent suture which I am putting, so 2 releasable, 1 intermittent. Once you have done that, the conjunctival closure is very, very important. Throughout this procedure, whenever your AC is collapsed, make sure that you reform with air or cohesive. I start using air because I want the visco to come out as much as possible, because you keep the visco for a long time, you will have a fibrinous membrane. Conjunctival closure is very, very important. Always make sure that you take an episcleral bite. If you don't do that, the bleb will recess behind, and then you will have difficulties and leak. So make sure that you take the anchoring suture at the episcleral tissue, and interlocking sutures are put into the conjunctiva, and that gives a very good tight closure in the limbus, and do it on either side. And once this is done, you can use subconjunctival decagenta, whatever you are comfortable with, and this is the way the twin site surgery is done. Coming to a single site, just a small, very small video clip. I still have 1 minute, 15 seconds left. So all terms are same. Only the thing is here the wound mark is 6.5 millimeter, because I'm going to do an SICS plus trap. So 6.5 millimeter is the flap size, or the conjunctival flap size. Identify the bleeders, cauterize the bleeder, again 6.5. And in this also I'm doing a triangular incision. There are different variations when you are doing SICS trap. You can do the triangular incision, you can do the straight incision, you can do a rectangular incision. But I'm used to triangular, and triangular gives us a better exposure. So you see the flap has to be uniform. And now the steps are same for SICS. Once you have created the flap, the 2 lateral lawns of the SICS surgery is created. The anterior chamber is entered with the help of a keratome. Side port is created, and all the SICS steps are followed, and then the internal ostium is created with the help of a Kelly sponge, and all these procedures are same. The remaining procedures remain the same, so there is nothing different in that. Only the incision size is different when you are doing an SICS trap, and the site is the same site technique. So this is what I wanted to talk about the combined surgery.
Thank you so much, Dr. Porwal, for your wonderful presentation of a difficult topic, and comprehensively covered through both the videos where you touched upon right from the incision to the conjunctival closure. Thank you so much. And now I'd like to invite Dr. Ankur Sinha for his talk on landmark studies on primary angle closure.
Yeah, Amit, wonderful videos. Just one point, I just noticed that in the phaco parameters, I think we should also stress that the parameter bottle height should be low, and we have to, because I noticed you had kept bottle height of 100, which gives IOP of about 70 millimeter of mercury.
Yeah.
So that becomes hazardous, particularly in moderate to severe glaucoma if we are doing combined surgery.
Okay, so as I told you, whatever is your preferred choice, go ahead with that. Slow motion phaco is preferable, but if you know that your CD count is less, your turbulence is less, you are going to finish your emulsification in a fraction of 20 to 30 seconds, then you don't have to worry about that.